Hey everyone, Ryan here from IKN. So in this video, we're going to discuss different spinal extension strategies that your clients may demonstrate when you're assessing their spinal extension in standing, okay, or their backward bend. Now, we refer to them here as compensations, but again, compensations aren't bad, but they're just different variations of the strategies that someone may use to carry out a similar movement task, okay? And a quick disclaimer here as well is that we're not saying that any of the strategies that are demonstrated in these videos is more likely to lead to a pain experience. We can't boil a pain experience down to how muscles and joints behave. Okay, it's much more complex than that. What we're looking at here is the variability of the muscular tissues, the variability of the segments. Okay, because when we're looking at spinal extension, we want a distribution of range of motion. We want multiple segments to contribute to the range of motion as opposed to that motion being concentrated at one local area. Okay. So generally, when we're looking at spinal extension and standing, we're looking for the rib cage to have the capacity to extend. And again, it's important to kind of use that language for the client to have the capacity to extend something, because it doesn't mean that they have to demonstrate that movement when they backward bend all the time. They just have to have the capacity to do it, to allow them to access more variability within how the muscles and joints behave. Okay, so we want the rib cage, thoracic spine to have the capacity to extend. Okay, but we also want the pelvis to have the capacity to flex or anteriorly tilt. When the rib cage and thoracic spine extends and the pelvis can anteriorly tilt and flex, that gives the lumbar spine the ability to extend. Okay, then further into the spinal extension strategy, we want that pelvis to have the capacity to shift forward. Okay, and that gives the femur the ability to extend as well. So we're going to get rib cage, thoracic spine extension, lumbar spine extension, a flexion or an anterior tilt of the pelvis. Okay, and an anterior weight shift. So the pelvis drives forward and moves over the toes, and that allows for the femur to extend. So we can distribute that range of motion over a broader surface area. Okay. Initially, when you're asking someone to backward bend, you want to see what their preferred strategy is like. Okay. You don't want to give them too many cues at the start. So you can see what their preferred strategy is like. Of course, you're identifying if there's any kind of sensitivity or pain with that movement. Okay. And that's different. So if they have pain with a movement, you're not saying, okay, whatever they're doing is an impairment or dysfunction. All you can say is that movement is sensitive, or that's an aggravating movement for them. Okay. But through a separate lens, you're looking at the variability of the muscles and joints. Okay. So when you're looking at pain or the symptoms and their aggravating and easing factors, for example, that's different to the variability of the movement system. Okay. Once we see the client's preferred pattern or preferred strategy, what I'll typically do is I'll kind of try and drive the client into a movement that gives me access or gives me a greater insight into, can they actually express those capacities at the rib cage, at the thoracic spine, at the lumbar spine, at the pelvis, and at the femur. So I'll have them put their hands on their hips, and I'll ask them to give themselves a big proud chest, and I'll have them use their hands to drive the pelvis forward and to point the chest up to the ceiling. Just those cues. Give yourself a nice big proud chest and use your hands to drive the hips forward and try and point your chest up to the ceiling. So it looks something like this. So I'm seeing there, do they have the capacity to extend the thoracic spine and rib cage and then flex the pelvis, which will allow for the abdominals to express more length, more eccentric behavior. And that allows for the femur then to extend relative to the pelvis. Okay, so we want to see that pelvis go over the toes. We want to see the shoulders just go behind the heels. Okay. So again, hands on hips, give yourself a nice big proud chest. Use the hands to drive the hips forward and try and point your chest to the ceiling. What you'll often see in many clients, again, is a limitation in segmental behavior, okay, or in segmental motion. So you might see something like this. You ask them to give themselves a nice big proud chest. You ask them to drive the hips forward, but what you see is this bending of the knee, okay? So in this scenario here, you're not really seeing any kind of relative extension of the femur, okay, relative to the pelvis. When people think of femoral extension, they think of the femur extending relative to an extended or posteriorly tilted pelvis. okay, where it's only the femur extending. That's okay when it's in isolation, but we're looking at a multi-segmental movement strategy here. So the pelvis will have to anteriorly tilt, but the femur will also have to extend to distribute that motion. In this strategy here, the knees are bending because the femur can't extend with the forward shift in the pelvis or with the anterior tilt. Now, we'd have to look at this a little bit more locally to see, is that pelvis actually flexing there, or are they just extending a lot at the thoracic spine and rib cage? Okay, so we would, of course, have to look at this kind of global movement strategy, of this global assessment on a more local level as well. Okay, but generally, when you're seeing this excessive knee bend, the femur is lacking the capacity to extend. Okay, but generally, if you can see this kind of nice length through the abdominals, the pelvis does generally have the ability to flex to allow for that length to occur. But then, if you're seeing that with the knee bend and the femur looks like it's still in line with the rest of the trunk, that femur is struggling to extend. You may also see this just a limited anterior pelvic weight shift. And again, it may look very, very similar to the last video that we just saw, where the client struggles to shift the pelvis forward. Okay, and you'll see just a lot of extension at the lumbar spine and at the thoracic spine. Okay, this is potentially a scenario where they're just concentrating that motion at the lumbar spine. Okay, via thoracic extension and potentially through an anterior tilt or a flexion of the pelvis. But again, we're not really getting any extension of the femur through that forward weight shift. Okay. Now, if you ask them to really try and drive the pelvis forward, you'd probably see more of a bend in the knee. This tends to be one that we see the majority of the time, where a client will struggle to distribute that extension into the thoracic spine. So when you ask them to give themselves a nice proud chest, they struggle to give themselves a nice proud chest, because to give yourself a nice proud chest, you have to be able to extend your thoracic spine. You have to be able to extend your rib cage. But what you're seeing here is you're seeing a flexion of the rib cage with a flexion of the pelvis. So in coordinative research, they would look at this as an in-phase strategy, where both segments are moving in the same direction. The rib cage is flexing, the pelvis is flexing. Whereas ideally, to distribute that extension across the spine, we want the rib cage and thoracic spine to be able to extend while the pelvis is able to flex. Those are movements in opposing directions. Okay, that gives the abdominals greater capacity to lengthen. It allows for a distribution of extension across the spine. Again, does not mean that this person is more likely to experience pain. All we know that is that this is likely concentrating a lot of that motion around the lumbar spine instead of being distributed across the spine. Okay, so if a client experiences pain with this or sensitivity, we just know that they're sensitive to that movement. Okay, we just know that this is an aggravating movement for them. Okay, that's all we know at this point here. Okay, it could be a case where we need to distribute more motion across the spine to have an influence over sensitivity, or we just need to condition the spine to handle that load more. So there's questions that we need to ask ourselves as to why they're experiencing sensitivity, instead of just looking at the variability of the segments. But it's important to have a perspective through both lenses. Okay. So hopefully that makes sense there. Generally, what we're looking for is, again, we have to have a model through which we're looking for, an ideal distribution of motion from a variability standpoint. So we want to see that extension of the thoracic spine and rib cage, flexion of the pelvis or an anterior tilt, the pelvis to shift forward and for the femur to extend. Okay, that allows for distribution of that range of motion across a broader surface area. Based on the strategies that a client is using, we can identify limitations in segmental motion. Okay, so let's say, for example, you identify that femur is really struggling to extend, and that's concentrating a lot of motion at the lumbar spine, let's say. Okay, we can't then just go in though and drive that femur into more extension. Okay, it's not really that easy. A lot of the times, I'm sure a lot of you that work with clients experiencing pain know that it's not that easy. We need to look at the movement excursion of the femur in that scenario. So let's say you identify that the femur is limited in extension, looking at this multi-segmental extension strategy. But what you need to do is you need to look at the variability of that femur through a full excursion. So can the femur actually flex? Okay. If, for example, you have a limitation in femoral extension, but you also have a limitation in femoral flexion, which you might measure with a forward bend, or you may measure via femoral flexion in more of a passive manner in a supine position. If a client's more limited in femoral flexion, then from our perspective, from a variability perspective, we would be more likely to try and improve that first, because femoral flexion will demonstrate a lot more variability in the femur. Okay, the femur can express a lot more movement when it's in a flexed position. So it gives us greater capacity to share forces between the femur and the pelvis in that scenario. And then we would begin working back towards a position that demonstrates less variability, towards extension. Okay, because it's not always as easy as identifying the direction of limitation and then just forcing them further into that limitation. We need to look at both directions, multiple directions of limitation when we're trying to restore variability, especially when a client is experiencing pain and has aggravating movements and has sensitivity. We can't, again, just drive the segment into the direction of limitation. We need to couple what modifies their symptoms, what has an influence on their sensitivity, with how we can restore variability. But like I said, restoring variability is not just about identifying the direction of limitation and then just forcing them further into that direction of limitation. Again, just one example of why we need to have a little bit more of a critical thinking process when we're trying to restore movement back into a segment. Okay, so hopefully that helps. Going to give you a little bit more information as to how you can structure your thoughts when you're looking at spinal extension.